This is ultrasound guided regional anesthesia for pain and trauma patients. I have no disclosures other than I'm not an anesthesiologist, but those who worked with me in the ED know that. I love teaching POCUS and especially nerve blocks. And before while in fellowship, I did 6 months of regional anesthesia at Vanderbilt. And then since then, I've been a member of the American Pain and Regional Anesthesia Society, where I've done an annual cadaver course to kind of do like a maintenance of skills. And then I help oversee the resident curriculum in regional anesthesia. So it's a lot of work to kind of keep that up, but it's something that I really love to do, and I will kind of just jump into this. So my objectives. Can you see most of the objectives on here?
Yes.
Okay, awesome. So objectives. So why perform nerve blocks at all? Why do them ultrasound guided? Why should we perform them early in the ED, specifically in trauma patients? I'm also going to review Atrium Health and CMC Maine's history with ultrasound guided regional anesthesia for acute pain in our ED, and also in the EM residency curriculum. I will describe the evidence and types of blocks, and I'm mostly going to discuss it for rib fractures. And then I'm just going to mention sternal, hip, and femur fractures. But honestly, it's going to be mainly just rib fractures, and then I'm going to end with a little bit of information just about femur fractures. Also discuss the importance of a multidisciplinary approach for managing pain in the ED and trauma patients. Review local anesthetic systemic toxicity, and I'm just going to say a quick line on compartment syndrome and blocks. Honestly, the main takeaway from this entire lecture is really just me advocating for early use of ultrasound guided regional anesthesia for pain and trauma patients, and really kind of starting that in the ED. So why blocks? So there is a huge push, and I know everyone's feeling it, about using opioid sparing measures and opioid sparing approaches, and using multimodal approaches for pain, whether it's rib fractures, dislocations, hip fractures. We all know the opioid risk leads to delirium, increased length of stay in the ED, increased length of stay in the hospital, respiratory depression, increased risk of opioid use. And we're all kind of practicing in a climate of a national opioid crisis. This particular publication is from Annals of Emergency Medicine on the Association of Emergency Department Opioid Initiation with Recurrent Opioid Use. This is a retrospective cohort study of all patients that were discharged, and their primary outcome was rate of recurrent opioid use. And kind of the take-home message of this was that opioid-naive ED patients that were prescribed opioid for acute pain had an increased risk of additional opioid use at 1 year. So, I mean, I think we're all trying to make a big effort to reduce opioids, and blocks are a good way to help control pain. Why specifically ultrasound guided nerve blocks? The fact that we can actually visually see our planes, visually see the nerve that we are going to block, it reduces the risk of intravascular injection, especially when we're doing femoral nerve blocks. There's a lot of vascular areas, even for blocks in for chest wall blocks. So it reduces the risk of intravascular injection, which therefore will reduce the risk of something called LAS, local anesthetic systemic toxicity, reduces the risk of complications such as pneumothoraces, nerve injury, and vascular injury. It increases our accuracy and success on doing blocks, because we can see directly where we're going to deposit our local anesthetic, and it decreases our time to perform blocks. And these are just 3 reviews from the anesthesia literature that goes through extremity blocks and just general blocks. So why should we perform blocks early? There is literature that says that analgesia is inadequate and or delayed in the ED, and some factors that lead to that issue are such issues such as ethnicity, gender, language barrier, whether it's a pediatric patient or whether it's a geriatric patient. So we don't really do a great job, honestly, of controlling pain in the emergency department, especially for trauma patients. And it can be a very traumatic experience in the emergency department when people come in as a result of an MBC or other sort of trauma. So, we can do a lot better in controlling pain. This is a particular study. I was looking for something related to rib fractures, but I found this it was in the Emergency Journal, is an Australian publication on the patterns of analgesia for femoral neck fractures in emergency departments. Um, and this was a study that included 36 EDs with patients with hip fractures. They included a total of 646 patients. And they concluded that the median time to analgesia was about 75 minutes, with a mean of almost 2 hours and interquartile range of 108 minutes. So that just goes to say that, we do not provide pain control early enough. And especially that's obviously a major issue with trauma patients. So just a little bit about our history of ultrasound guided regional anesthesia in the ED. So around 2018, we started a project with one of our seniors who had graduated on using fascial compartment blocks specifically for fragility hip fractures. This was something that we had discussed with orthopedics, and at the time we had also discussed it with anesthesia, so we could protocolize getting this started. So this kind of jump started our block program and doing more blocks more readily in the emergency department. 2 years later, we submitted a QI project on collecting data on all our blocks done in the emergency department. So we've been doing that since 2020, looking at our blocks' successes, failures, complications, also looking at patient satisfaction and provider satisfaction with providing these blocks. And then also in that same spring of 2020, we started a project with one of our seniors, Jake Liederkirchen, who graduated, on more systematically performing ESP blocks, which I'll discuss more in a little bit, and serratus anterior plane blocks, specifically in trauma patients for rib fractures. And this is something that at the time we did discuss with trauma about being able to provide these kind of in a timely manner when patients came in, so there's no delays in pain control. Also at that time in 2020 was we provided our first kind of introduction to nerve and fascial plane blocks in the emergency department. And it's something that we've provided every year since then. So in April of 2021 was our second annual introduction to nerve and fascial plane blocks in the emergency department. And then in July of 2022, very recently, we had our third annual introduction to nerve and fascial plane blocks in the ED. So we've come a long way since 2018. And kind of rolling out something that was protocolized and done in collaboration with either orthopedics or trauma. So how do we manage emergency department pain for rib fractures? So I think you all are pretty familiar with kind of the multimodal pain approach. We try to use a combination of IV pain meds, whether it's opioids, which we try to use sparingly, of course, pain dose ketamine or ketorolac, also topical 5% lidocaine patches, which we use in abundance in the emergency department. Obviously, nerve blocks is something that we've integrated more. Intercostal blocks is something that we actually don't do as often, especially since better blocks that kind of cover a greater number of blocks have come out, like the erector spinae plane block, serratus anterior block, and something called a mid-transverse process block. And then lastly, pulmonary toiling is something else. Everyone who comes in with rib fractures provided with an essential spirometer. So which blocks are we doing in the emergency department and which ones are we using specifically in trauma patients? What injury pattern do they cover? What are their indications? And what is the evidence for using these blocks? So in our emergency department, what we're currently doing right now is for upper extremity blocks, which is in green, we are doing either interscalene or superior trunk blocks, and that's really a more advanced block that our fellows are training to do. And that's something that we're doing really for shoulder dislocation, so that we won't have to otherwise sedate somebody, especially if it's busy. going to take up resources. So we are doing interscalene and superior trunk blocks for reducing shoulders. We're doing forearm blocks, especially for hand injuries, reducing boxers fractures or complex hand lacerations. For lower extremity blocks, we're doing fascial compartment blocks or femoral nerve blocks for femur fractures. We are doing sciatic popliteal blocks, especially for ankle fractures, which covers the majority of the osteotomes for ankle fracture dislocations. And then posterior tibial blocks is really the main block of the 5 ankle blocks that we do that covers the whole plantar surface, which we use as well. As far as truncal blocks is concerned, which is mainly related to trauma, we're using serratus anterior plane blocks specifically for anterior rib fractures, and then erector spinae plane blocks specifically for posterior rib fractures. Other kind of blocks on the horizon that will eventually integrate into the residency curriculum will be farther down the line, parasternal blocks for sternal fractures, and then a new block for hip fractures called a PANG block, which is something that came out in the last couple of years. So kind of comparing what we do in the emergency department to what anesthesia does. Can everyone see my cursor, by the way? Is that a yes or no? Anyone?
No.
Oh, you can't see my cursor at all? Okay, well, so the 3 types of blocks that we're using, the 2 types that we just discussed right now, the serratus anterior plane block and the erector spinae block, are one-shot blocks, meaning we deposit 1 large volume local anesthetic. Serratus anterior blocks are about 20 to 30 cc's. Erector spinae plane blocks are pretty large volume blocks. They're about closer to 40 cc's. We are adding dexamethasone to all our blocks to make it last longer, so that it's closer to 24 hours of coverage. There is another block that will eventually, we might integrate into the curriculum, which is something called a mid-transverse process block, also for rib fractures, and that is a one-shot block. This is compared to what anesthesia does. So we do not do paravertebral blocks, which are that and epidurals are kind of the gold standard for covering both posterior and anterior rib fracture pain. And anesthesia does both one-shot blocks, but I believe they're mainly doing placing catheters, especially for paravertebral blocks. Paravertebral blocks aren't a block that we normally do. It is definitely a more advanced block, advanced. You are very, very close to the pleura, in fact, pushing the pleura down with local anesthetic. So unless this is a block that you do very, very routinely in your practice, it is considered a pretty advanced block. So it's something that we're not doing, but I just wanted to kind of compare what we were doing in the emergency department versus kind of more advanced blocks that anesthesia does. As far as location, so this is a transverse cut of the thorax, and these are the different locations on where local anesthetic is being deposited for these chest wall blocks. So anesthesia is that's in these red letterings, are doing epidurals, which is a more central deposit of local anesthetic, and it's something that's really contraindicated in patients that might be on anticoagulation or might have concomitant spinal or head trauma. And then thoracic paravertebral blocks, like I mentioned earlier, is another advanced block that regional anesthesia does, but it's also a block that can't be done in patients on anticoagulation. So, I mean, a huge issue we have in the emergency department is that pretty much everyone who is on anticoagulation decides to ride a motorcycle in Charlotte and breaks all their ribs, both posterior and anterior. And it's been really kind of quite a challenge, especially with boarding these days and keeping patients a lot longer in the emergency department with controlling pain. So I think blocks that have fewer complications are blocks like the ESP block and serratus anterior plane blocks. So paravertebral blocks, I'm not really going to discuss that much of it, just to kind of compare it to the blocks that we do in the emergency department. It's depositing a local anesthetic into the paravertebral space. It is they are going to cover posterior and anterior rib fractures. Here on this purple arrow at the bottom of the screen, pointing towards kind of the green distribution. Paravertebral blocks is the theory behind it is that it blocks both the ventral and dorsal rami, and so gets coverage on the anterior and posterior portion of the chest wall. They're an excellent block. But obviously, like I mentioned before, there's a lot of contraindications, including if a patient has a spinal injury, this might not be the best block for them if they're on anticoagulation or if they have any trauma-related coagulopathy. And some of the complications with these are pneumothoraces and hematomas. The volume for these blocks are about 20 to 30 cc's. The block that we have been doing more often since 2020 has been the erector spinae plane block. This is performed with patients either sitting up or laying on their side. I have found it challenging to lay most trauma patients on their side because they usually have some other injury that prevents them from doing that. So usually we do this block with the patient sitting up. This block was kind of the in vogue block when it came out a couple of years ago. They were using it for everything from renal colic to all sorts of indications. At the beginning, we thought that this would cover posterior and anterior rib fractures, but in our experience, it seems to cover mainly just posterior ribs, and covers 2 ribs above and 2 ribs below. And in the figure here on the right-hand side, there's 2 purple arrows facing up. So the erector spinae plane block, our needle is actually touching the transverse process. So that's kind of our backstop. This is a relatively easy block to do, but it's also an easy block to kind of mess up because you really have to get right under the erector spinae muscle and really kind of hydrodissect it and lift it up off of the transverse process to be in the right plane. It's very easy to have your injection in the muscle. And then this is just kind of comparing it to the location where you would do a paravertebral block. Like I mentioned, paravertebral blocks are really great at covering both anterior and posterior rib fractures, but erector spinae blocks really seem to just cover the posterior ribs. They do, like I said, cover about 2 ribs above and 2 ribs below. We've had patients where they fractured everything from rib 2 to rib 10. Either on one side or have had bilateral rib fractures. So we've been able to do either 2 blocks on either one side of the chest wall or just bilateral blocks, making sure that we stay below the toxic dose for the local anesthetic we're using. Contraindications, I mean, if we can't put, if the patient has a spinal injury, but if we also just can't perform the block if there's no way to either sit the patient up or have the patient lie on their side, because we really have to do the block come in from a posterior approach. It's a relatively safe block. You would really have to lose your needle tip to cause a pneumothorax and do lots of redirections of your needle to cause a hematoma. And like I said before, these are high volume blocks, about 40 cc's. This is a block that was performed in our ED. It looks like they got a little bit of local anesthetic in the muscle, but you see this hyperechoic line kind of making contact with a transverse process. And you see kind of this breathing of the erector spinae muscle with the injection. The muscle kind of lifts up and then kind of expands and then contracts as they're giving aliquots of local anesthetic. I'm going to go into a little bit of a quick review on in the next couple of slides on data for erector spinae plane blocks, but I just wanted to quickly just give a little information on prelim data, specifically with our experience with erector spinae plane blocks. In 2020, like I had mentioned, we had done a prospective observational pilot study from March of 2020 to April of 2021, looking at patients 18 and older that presented to our emergency department with 2+ rib fractures. Kind of the aim of this was Are emergency physicians able to safely and successfully perform erector spinae plane blocks and serratus anterior blocks in the ED for rib fractures? And kind of our secondary aim was tracking changes in pain score, incentive spirometer volumes, cough score, opioid reduction, and complications. And just this is just unpublished data right now. From during that time period, we collected 31 blocks with complete data that was performed in the ED, of which 97 of those were ESP blocks. The limitation of this is we had a low volume of complete data, so it was only 31 blocks. We collected this data during the height of COVID, where nobody wanted to come to the emergency department or be near an emergency room, and so we do not have a large number, but from these 31 blocks that we analyzed, 90% were successful blocks. We had a 0% complication rate, and we did show a decrease in pain scores. We tracked these patients inpatient at these time intervals from 6 to 8 hours, and then 10 to 12 hours. And then we also saw an increase in census spirometer volumes. So this slide kind of just quickly sums up like why use ESP blocks. This is numerous articles, and I'm not going to go into them for the interest of time. But there is a reduction in opioid use with ESP blocks, good pain control up to 24 hours when using continuous catheters versus either an epidural or intercostal block. It's associated with improved IS scores and analgesic outcomes. And so there is lots of data supporting that we should be doing this in our patients. So just going to briefly mention mid-transverse process blocks. It's pretty much essentially the midway between a paravertebral block and an ESP block. And that's all I'll say about that. This slide kind of sums up the different areas where you deposit local anesthetic for these blocks. And our serratus anterior blocks, it's something that we performed in the mid-axillary line. Contraindication, it's not a hard contraindication about anticoagulation, especially if you can compress the site. But complications of this are pneumothoraces, hematomas. There is an artery that runs in this mid-axillary line, which you can puncture. So it's important to make sure that you identify that. And this is also a large volume block of about 30 to 40 cc's. This is what the sono anatomy looks like on the left hand side of the screen. And on the right side is kind of patient positioning for performing serratus anterior blocks. And you can either perform these this is the latissimus dorsi right here that looks like a triangle overlying the serratus muscle. You can either deposit local anesthetic either in between the latissimus dorsi and the serratus anterior, so on top of the muscle, or you can perform these blocks on top of the rib and kind of lift the muscle up from the rib. And this is just a case that we had with our fellow. She's performing a serratus anterior block, and she's hydrodissecting on top of the serratus muscle and below the latissimus dorsi for a patient that had numerous anterior rib fractures that was in a motorcycle accident. And we had difficulty controlling his pain because he also had a prior history of opioid use and did not want to use any opioids. So what's the evidence for serratus anterior plane blocks? This is a multi-center longitudinal cross-sectional study comparing the effectiveness of serratus anterior blocks to kind of the two gold standards for rib fractures, paravertebral blocks, and thoracic epidurals for analgesia and multiple rib fractures. This is a publication in 2020 in the Journal of Regional Anesthesia and Pain Medicine. This is data from two major trauma centers for the indication of traumatic rib fractures. This study included 354 patients. The primary outcome was change in IS volumes and pain score. Secondary outcomes was in hospital mortality, length of stay in the hospital and ICU. And the results of this study show that across all blocks across for the serratus anterior versus paravertebral versus epidural, there was an increase in IS volume. There is a reduction in verbal pain score, and there was no difference in the change in IS volumes across all blocks. And just kind of goes to say that serratus anterior blocks are also really good blocks to perform. Although I will say this specific study did not seem to specify the fracture patterns and did not seem to stratify by posterior versus anterior rib fractures, which I thought was a little bit interesting, since serratus anterior blocks really just get the anterior ribs. I am just going to quickly go through this so that I have time for a question and discussion. Like I said, in 2018, we started doing fascial compartment blocks for hip fractures. There's loads of data that support doing this. This should be the standard of care in honestly all emergency departments. For hip fractures. On the bottom right-hand side of the screen, it shows the osteotome, so it's the innervation specifically to the bone. The hip gets innervation from the femoral nerve, the obturator, and the sciatic nerve. So fascial blocks really are basically just compartment blocks that really mainly just block the femoral nerve as it feeds the femoral neck. These are really just femoral nerve blocks, essentially, in the fascial compartment. So these should reduce pain, but these will not take pain to zero, since obviously there's other nerves that also give sensation to the bone. But there are numerous studies, and this was just a review of regional anesthesia for hip and femoral neck fractures in the emergency department that shows improvements in pain scores, reduction in IV opiate use, and to show that there was no complications from these nerve blocks. This shows just more evidence to show that there's a reduction in respiratory complications when doing more nerve blocks, specifically this is evidence for hip fractures, decrease in delirium for patients, specifically our geriatric patients, and less narcotic use. And again, showing that these fascial blocks are as effective as opiates with regards to pain control without all the complications. This is just an example. This isn't a how-to lecture, but just to show you kind of what it looks like to perform a fascial block. So this is a right-sided block for a right-sided hip fracture. We use echogenic needles called Payunk needles. They're nerve block needles that we use for all of our blocks. And this is just showing the hydrodissection and the iliacus muscle kind of peeling off from both the nerve and the fascial to get into the right compartment for this block. Just a little bit of word about interdepartmental collaboration. This is a recent publication in regional anesthesia and pain medicine by a group from Brigham, 2021, that talked about kind of creating more of a multidisciplinary collaboration to increase access to regional anesthesia. Our regional colleagues definitely have a lot of work to do upstairs, a lot of blocks to do, a lot of catheters to place, and it's very challenging to also come down to the emergency department. And kind of furthermore, it's been to be able to kind of treat the large volume of patients that we see, it's really going to take a collaboration between regional anesthesia and the emergency department to be able to kind of provide blocks in a timely manner, for all of our trauma patients. And a quick word about local anesthetic systemic toxicity. So just be aware about it. There is a spectrum. There's a prodrome that's really something that you would see with lidocaine. For the long-acting blocks that we're using, there's a higher risk of local anesthetic systemic toxicity. Local anesthetics are sodium channel blockers. If you give enough of it, especially if it's a long-acting local anesthetic like ropivacaine and bupivacaine, we can cause CNS effects on the spectrum of LAST, which are seizures, coma leading up to cardiac issues such as hypotension, arrhythmias, and even cardiac arrest. So it's our practice in the emergency department to place everyone on a monitor when we do large volume blocks, specifically with bupivacaine. It does not start in the prodrome phase. It jumps straight to the CNS phase and then escalates quite quickly to cardiac arrhythmias. And if you've never had a patient that has had LAS, it can be pretty scary. I haven't. I think if you do enough blocks, I'm sure you will encounter this. And I'm sure that's something that at least with as many blocks that are done upstairs, I'm sure there's been one or two cases. What we do in the emergency department to kind of monitor for this, we calculate our toxic dose for all of our patients. There's a form that the residents fill out. We stay below the toxic dose. We place all patients on a cardiac monitor before blocking them, and then reassess the patient and also reassess the block to see if it's working after 20 or 30 minutes. We have this posted up in the emergency department. It's from the American Society for Pain and Regional Anesthesia on using intralipid, which is the treatment for LAST. Intralipid is what we have in major in the front rooms in our remedy Omnicell that has all the different antidotes for overdoses. And so intralipid is included in there. And so this is posted on our block cart, which we're going to start using in the department, and on our block cabinet. And it's also on all our block sheets in the emergency department. This is something that's also on the block sheets that the residents use. It's the pharmacology dosing guide. The local anesthetics that we mainly use are 0.5% ropivacaine for our long-acting blocks, which we add dexamethasone to. This should actually say 5 milligrams, not 4 milligrams, because we're using the preservative-free dexamethasone, and the hospital uses 10 milligrams in 1 cc. So we would use a 0.5 cc per single shot large volume block. For shorter acting blocks that we need to do to facilitate either a complex large laceration or just fracture reduction, we'll use a short acting local anesthetic like lidocaine. I will mention that while we have the max toxic dose is right here in this center column for milligrams per kilogram. I just kind of want to remind everyone who uses local anesthetics that there is a ceiling for these local anesthetics. So even if somebody for their weight-based dosing goes over, for instance, lidocaine over 300 milligrams, and it's 10 milligrams per cc, and it's not that hard, especially for really complex laceration repairs. If you're actually putting the local anesthetic directly on a wound, that's a complex wound. It's very easy to get to 300 very quickly and to even exceed that. So I think it's important to remember that there is a max dose for these local anesthetics that we try to not go over, even if the weight-based dosing goes above them. And these are just photos from our block cart from different drawers with our supplies. And on this left photo, we have the block needles that we use. And then I just wanted to, this is my last slide, quickly talk about regional anesthesia and compartment syndrome. This is definitely a very controversial topic. This is a review that just came out in September of 2022. It's a very good review on acute extremity compartment syndrome and regional anesthesia. Basically, the punchline is that we don't really have good data on any sort of kind of a association between nerve blocks and compartment syndrome, or that nerve blocks even cover up the type of pain that lead to compartment syndrome. I'm sure lots of people have opinions about that, but this is a really good review, so I'd recommend reading it. Actually, this year, a couple of good articles did come out just discussing kind of this controversial issue. But again, just to highlight that we do not have good data about this, and this is something where I think creating a registry would be good and kind of give us more information about any issues between regional anesthesia, kind of masking compartment syndrome, but there's not good data about right now. And that is it. I will wrap up. I think I have time for questions. I know I went really quickly.
Great. Thank you, Dr. Fraga. We will open it up for questions. I don't see any hands yet, but I can start with one. I wanted to ask you about the serratus anterior blocks. We don't, to my knowledge, we don't see that very often with all of our rib fracture patients. Maybe y'all are doing it more than I appreciate, but I see that as any time we were going to do something invasively, we always worried about anticoagulation. And I guess I would say that it would be great to even be more aggressive with those with all our rib fracture patients. That's a potential space. And even if they're anticoagulated or we have some bleeding, it shouldn't really cause much of a problem. So I guess my question to you is, how often are we doing those for lateral and anterior rib fractures? Because the lateral ones are the ones that really are limiting folks in their pulmonary status. Those are the ones we really target for operative fixation. So sort of what's the status of the serratus anterior block?
So I'll say 2 years ago when we started teaching this block, I think everyone touted the ESP block as really covering anterior and posterior rib fractures. So preferentially, we were doing a lot more ESP blocks than serratus anterior blocks. And anecdotally, at least I have found that ESP blocks do not get very good coverage of the anterior ribs. Since then, the last block course that we taught in July, I was talking about this again about how with patients with anterior rib fractures, we should really do more serratus anterior blocks instead of erector spinae plane blocks. So it's something that we were not previously doing that much of, just because ESP blocks were kind of this catch-all block that everyone was doing and saying that it catches the anterior ribs. I think the theory behind it is that you give such a high volume that it should spill over into the paravertebral space to get that dorsal ventral rami to cover the anterior ribs. But honestly, it really, in my experience, does not get the anterior ribs. So it's a block that we will be doing more frequently for specifically for anterior rib fractures.
That's great. I think those of us in the rib fixation business would absolutely support it. And maybe even we would love to watch you do it. Then maybe some of you guys come to the operating room and see that space once we expose it and see how it works. There's a question in the chat from Angela Clarkson: with ED providers utilizing this pain management technique, who's coming up to redose if needed once the patient leaves the ED? And then as a follow-up, if they're going to be discharged, how long do they have to wait before being discharged?
Upstairs we have a regional anesthesia team, a regional anesthesia and pain service. So once people go upstairs, I think the trauma service has experience with working with the acute pain service. So they will either do blocks in the OR preoperatively, or like paravertebral blocks, or they'll place catheters once patients are on the floor. If they need multiple days of pain control, they'll place paravertebral catheters. So it's really the acute pain service, to answer your question, that is doing those blocks upstairs. What was the second part? I think of.
So if they're going to be discharged, how long do they have to wait before being discharged? Which I'll let you take it, but it's
Yeah. Last local anesthetic systemic toxicity, if it's going to happen, it's really going to happen kind of early in the course, probably within like the first 30 minutes. And I make the residents recheck the blocks after 20 to 30 minutes just to make sure the block worked. Even so, so say for instance, there is a young person, the only thing like holding up, because we've had this before, we've had trauma patients that were discharged and essentially came back, and it was always a young person that was still having pain, and it was like 2 days after discharge, and they're still having rib pain, and it was just kind of slightly uncomfortable and nothing major that would otherwise cause them to need to be admitted. Those are patients that can get a block. Of course, they're only going to get pain control for up to 24 hours or 24 hours and change by adding dexamethasone. But it's something that at least it would provide pain control for that 24 hours so that patients wouldn't have to be admitted. But to kind of answer your question, we're, again, watching them for about 30 plus minutes, probably no more than an hour, because it takes about 30 minutes for us to check to make sure the block worked. And by the time we get around to doing the discharge paperwork and sending people out the door, it's about an hour. So if local
That may, yeah, that may answer the next question. Dawn has asked, do we reblock once it wears off? I guess if it's already wearing off, they're still in pain. I'm sure we're admitting them by then anyway. And so the answer would be yes. We might reblock upstairs, or we'll just have them booked to go to the operating room for fixation and block there. But do you have anything to add for that? Do you reblock when it wears off?
Yeah, I mean, and I imagine a lot of these trauma patients, I mean, have some pretty wicked rib fractures. I mean,
Yeah.
they're fracturing like 2 through 10 posterior ribs and all their anterior ribs, and sometimes it's bilateral. And I mean, a one-shot block is going to get them through boarding in the emergency department, but I mean, the next day or even in the middle of the night, they're going to start having pain again, of course, and they're going to need a catheter. And then that's, of course, regional anesthesia will take care of that.
Right. Right. There's also a request to get a reference list from the literature you cited. So if you have a reference list from this presentation, it's really terrific. So if you could share that, we'd be happy to distribute that to the participants as well.
Yeah, absolutely.
Any other questions? There's Dr. Diefenbacher.
Yeah, quick question on the use of Exparel in terms of its efficacy and maybe some extended duration versus the cost. And if you guys have even considered that, or what your thought process is there. Thanks.
So yeah, a couple of years ago, we had talked about, actually it was in 2018 when we were talking about the fascial compartment block. Everybody was talking about Exparel. It was really expensive. It was a liposomal bupivacaine, and how it was like lasting up to like 3 days for blocks. My understanding is that it has not panned out. We are not using Exparel for multiple days. It is slightly pricey. I don't know how pricey it is. I'd have to ask pharmacy on that. But it's I think people were excited about using Exparel a couple of years ago, but now not as much.
Yeah, I think that's kind of what we've seen too. And I think one of the challenges is if we do Exparel early, then it it prevents us from doing additional blocks either in the operating room or 24 hours later. And so when we do the shorter acting blocks, it gives us the opportunity to fine tune our block or do a different one in conjunction with our operation too. So agree with you. We were doing a lot of Exparel for quite a while, and it seems like we've almost universally gotten away from it.
Good points. Other questions from the group? Right. If I'm missing someone, speak up. Otherwise, I'm not seeing any others. So we can go ahead and wrap it up. If you've got, Dr. Fraga, if you do have a reference list. So the one that you did post one that was from a hospital in the UK, which I happen to know is not doing any rib fracture work. So I'd be surprised that I may have to dig into that one and see what their outcomes look like in the face of non-operative management of all their complex rib fractures. So for those of you that don't know, we are doing a ton of operative management. So this is a great and very timely presentation for us in our rib fixation endeavors. So we have a lot of opportunity to team up and make this better from the time of presentation all the way through discharge. So thanks very much for being here and presenting with us today. Appreciate your expertise, and unless there are any other questions, we will go ahead and wrap up our session. All right, everybody have a great rest of the day.
Thanks
again.